Hi everybody, I'm Angelo Karunaratne. I'll just quickly give a kind of introduction to wavetec and also the objective of this webinar, and also I'll introduce our panelists here. So wavetec is a startup incubated in MAS Innovation Twinery and fully owned by MAS Holding, one of the largest apparel and garment manufacturer in South Asia. So wavetec, from wavetec point of view, what we actually do is an innovative startup that we provide active pneumatic compression solutions. We offer an array of integrated technologies such as sensors, compression sensors, haptics, heating and cooling solutions, which will enhance the circulation. By doing that, we improve the circulation and rejuvenate tired and achy muscle. And our technology is catered towards mainly improving circulation. That's why we are offering few other add-on technologies as well. We work with industrial partners by providing circulation enhancement technologies, and also to try to be building the thought leadership within this space. So, which will give a kind of a segue to this webinar that we are going to talk about trend forecasting the 52 billion health tech market. So we have three panelists that joining with us to give us insights on compression technologies, and also what are the existing tools that are available, and also how we can improve these technologies going forward. So Dr. Parakrama, he's a sports expert. He's a consultant orthopedic and sports surgeon at National Hospitals in Sri Lanka. And also he's the official orthopedic surgeon to Sri Lankan cricket, rugby and football team. And then we have from the health and wellness angle, Dr. Sonia Rawal, assistant professor of physical therapy, University of St. Mary, a clinical researcher also who conducted a multi-center study examining the effects diet and exercise therapy patients with diabetic neuropathy. And from the medical angle, we have Dr. Thushan Gooneratne. He's a consultant vascular and transplant surgeon, North Colombo Teaching Hospital. He has a very high track record and pioneer with vision of develop and commercialize circulation devices to improve quality of life. So with that introduction, I would like to move on to Dr. Thushan to kind of, if you can give us a kind of a background to the webinar, and also to set the scene by providing some insights on background to the circulation in the healthy human body. Dr. Thushan, over to you.
Thanks, Angelo. Absolutely, I think before we get into the nitty-gritty aspects of things, it's important to just understand how the basic physiology of circulation works and why compression is required at some point in all of these. If you just look at the lower limbs and the concept and the principles applied to the upper limbs and the rest of the body as well, but we have a heart that basically pumps blood from the circulation system, and this travels along what are called arteries, which are vessels that take the blood down to the foot. And this happens devoid of any external influences. Even if you're lying down, even if you're standing upside down for that matter, blood will still flow through the pumping action of the heart and reach the feet. Now, the blood that does reach the feet needs to come back into the circulation, and that is why what are called veins. Unlike the arteries, as the arteries break up into tiny little branches and form what are called capillaries, and then they form veins, that pumping action of the heart no longer exists at that point. And we all know any liquid travels basically from a high pressure system to a low pressure system. And there's a need to create a high pressure system at the bottom of the feet for the blood to travel back into the circulation. And that pressure head is basically created by muscle pumps. And there are two basic types of muscle pumps, mainly one in the feet and then one in the calf. So if you're walking, if you're doing stuff, then the the blood in the feet will basically reach the calf. And as we are walking around, the calf muscles squeeze and the veins get squeezed around these muscles, and the blood gets pushed up. The blood that gets pushed up needs to stay up, and that is through what are called valves. And the valves in the system make sure that the blood doesn't flow back down to the foot. So for the system to work properly, you need a pumping action of the legs and the feet and the calf. And also we need functioning valves to make sure the blood stays up. If that doesn't happen, there's going to be stasis of the blood and causes venous hypertension. Now, the one in the green is slightly different. Some of the blood that reaches the feet by the arteries, a little bit of it, tiny bit of it, basically escapes the blood vessels and they go into the tissue space. And that fluid is called the lymph. And that lymphatic fluid reaches the circulation through a different circulatory system called the lymphatics. So when it comes to compression and circulation, how things work, we need this lymphatic system and we need the venous system in order to make sure the blood doesn't, or fluid doesn't accumulate in the legs. And if the deficiency is either in the lymphatic system or in the venous system where the valves aren't working, i.e. there are varicose veins or the muscle pumps aren't working, i.e. could be old people or elderly people who don't get up much, who stay on a couch or lounge chair for a long time, or after a trauma, after surgery, can't walk that much, the pumps don't work, then there is fluid that accumulates and that causes what is called edema. And in these people, that is where compression comes into the place or into this whole picture of medical and health and wellness issues. We need to create an external pressure in the feet so the blood basically can help to travel back into the circulation. So I think just to, in very simple terms, just to understand how the circulation system works and at what point in this system where if there are faults in the system, there's a risk of developing fluid accumulation and edema, and how compression helps to sort that out. I hope that's clear, Angelo.
Yeah, that's great, Dr. Thushan. I think you have covered the circulation system in the human body and how it's get kind of impeded, and also the importance of external compression. So I would like to turn to Dr. Sonia to understand how circulation system get impeded, how the compression can improve the circulation, and if you can touch on a little bit on manual compression as well. That would be really great.
Yeah, sure. Thank you, Dr. Angelo. Very nice introduction, Dr. Thushan. So I'll just move forward from where he left. Dr. Thushan very nicely explained how does the circulatory system and everything works in our body. So when we have the fluid accumulation in our body, so I would actually start by saying that traditionally in physical therapy interventions, whenever there is a soft tissue injury, there's a sprain or a muscle injury, what we usually traditionally do is called as RISE, which is rest, ice, compression, and elevation. That kind of very well signifies the importance of compression right there. So when we apply compression, especially the pneumatic compression, what it does is that after the injury, because of swelling, the blood vessels, they leak the fluid and the fluid goes out, there's swelling, there's edema. When we apply that compression, it pushes that fluid back into the blood and it allows the blood to go back to the heart again. So while it is doing that, what it does is while the swelling goes back into the blood vessels and then to the heart, it is also carrying with it the different enzymes and different waste products. So like lactate dehydrogenase or different other waste products. And when those are also removed, there is reduction in pain as well. So here we are talking about reduction of swelling. And then here we are also talking about reduction of pain. So compression does both of that. Now, along with that, especially with pneumatic compression, when there is compression of the device, stoppage of blood flow, then again filling of the blood vessels, what it does is it is increasing the blood flow and then again less blood stagnation. So less formation or less chances of forming deep vein thrombosis. So we saw swelling reduction, we saw reduction of pain, reduction of waste products from the site where there was an injury. In normal people or people who are immobile, increased blood flow and then reduction in the in the risk of forming the blood clots. Now, if I move from these injuries to people like cancer, where in those people where the lymph nodes are removed and these lymph fluid cannot go back to the heart, it results in lymphedema, which is accumulation of lymph fluid in the interstitial spaces. So when there is lymphedema, again, we are talking about importance of compression. With lymphedema, fluid is accumulated in the interstitial spaces. We are providing this compression, and this compression creates extra pressure, which forces the fluid to move back to lymphatics, from lymphatics to veins, and then to the heart. So reducing the lymphedema as well. Compression is considered one of the component of complete congestive therapy, which physical therapists do. In complete congestive therapy, there are different sets of things that we do. We do manual lymphatic drainage. We do compression after the manual lymphatic drainage, and we also do some rehabilitative exercises so that all of these can help with reduction of edema and then maintenance of that reduction of edema. So while we do manual lymphatic drainage, we just stimulate those lymph vessels to contract, to do this rhythmic contraction so that fluid from the interstitial spaces can go back to the lymph vessels and then to the vein and then back to the heart. So manual lymphatic drainage is traditionally has proven that it is very effective in reducing edema. Along with that, compression to maintain and reduce, and also some of the rehabilitative exercises that we do. So these are the traditional therapies, I would say, that we do for lymphedema. That would be the complete congestive therapy.
That's great, Sonia. Would like to turn to Dr. Parakrama just to understand a little bit from the sports angle. So we know from sports athletes also need to have a good circulation in order for them to perform well, and also after exercise they need to have a good recovery, and also post-surgery recovery also will need some form of compression for them to heal back. Dr. Parakrama, would you like to give some insights on recovery, sports recovery angle, and also the importance of compression?
Thank you. Thushan already set the platform for me to talk on the question that you asked from me. Sports, like when the blood is pumped out of the heart and it goes into goes through the arteries into peripheries. When a sportsman take part in a sporting activity, due to several factors, the blood vessels in the periphery get enlarged, and then the leakage of fluid out of the blood vessels will get more and more, and then there's a need of a lot of blood to be pumped back into the heart through the veins. So that mechanism has to be very well maintained, either by physiological means or by artificial means, by using mechanical compression devices, which already being used by lots of sportsmen by wearing tight underclothes, and that would definitely help them to bring out or bring the waste products that Sonia talked on back to the venous system and then back to the heart without allowing it to accumulate in the periphery. So that is the basic need of a normal sports person by using a compression device. But then if I am to elaborate or talk on how it is useful in injured sports person or a post-operative sportsman or anyone post-operative, is quite important, because surgical trauma automatically leaves some extravasation of blood into tissues, and on top of that, as a reaction to that, there will be extra leakage, and then reactionary fluid formation in the periphery. So that leads to swelling again, and then that is called edema, and that causes pain. So manual compression, which Sonia talked about, as well as mechanical compression devices, would help the sports person or anyone who's recovering from a surgery to bring that blood back into the system, so thereby reducing the swelling and reducing the recovery time that a person would need to come out of a surgery.
Thank you, Dr. Parakrama. Would you like to touch on a little bit on blood clots development and how compression can help prevention of creating developing blood clots?
Since I'm a general orthopedic surgeon who has special interest in sports surgeries, I would touch upon certain areas like, for example, we do replacement surgeries, hip and knee replacement surgeries. So these are the people, I mean, that is age, those who require this surgery are the age group who are like over 60 years, 70 years, 80 years. So they are generally, they tend to be sort of bedridden following the surgeries. And certain things that Thushan mentioned on, their valve systems don't work as much as or as good as in a younger person. So, and then their bed confinement, general ill health, and then malfunctioning or dysfunctioning valves leave them more prone to develop peripheral blood clot formation, deep vein thrombosis formation. So that group definitely would benefit from a mechanical artificial compression device, which would stimulate the peripheral pumping system to bring the blood back into the heart and then reduce blood clot formation, thereby reduce deep vein thrombosis formation.
Thank you, Dr. Parakrama. Sonia, so you talked about manual compression, MLTR. So can you elaborate a little bit on the other methods that we have to provide external compression, such as static compression sleeves, wraps, and also what Dr. Parakrama just mentioned about mechanical pumps? If you can touch on those things and also talk a little bit about pros and cons of static versus active compression and where we can really use them, that would be great.
Yeah, so if we kind of divide these compression devices into static and dynamic. Static could be our bandages or our socks, stockings, the garments that we use. And dynamic could be the pumps and the sleeves that we use. These pumps then can further be divided into different types. There are so many types available in the market. They could be single chambered, like the whole limb has just one chamber and they could provide just one constant pressure, or there could be multi-chambered, so they could be like different chambers for different parts of the leg, and different types of pressure could be applied at different parts of the legs. So either there could be more pressure required for a specific area of the limb. For example, if there are more scars, like heavy scars, that area could require more pressure. So you could gradually adjust that. And then there are some which allow like a calibration of different segments of that pump. So usually when we have multi-segmental calibrated or gradient pressure chambers, what they do is they would usually have more pressure in the ankle and then have lower pressure towards the proximal part of the leg, because you want to make the blood flow from the lower extremity, the distal part of that extremity, to go up. So they'll usually have more pressure at the bottom level. So usually when we do the complete congestive therapy for cancer patients especially, we usually do the manual lymphatic drainage and usually use the static bandages, the static devices, bandages usually. And then when enough swelling reduction has taken place, then we move from bandages to the garments. And these pumped or pneumatic compression devices, they have, that's the traditional method. I would say static is the traditional method. Dynamic, now they are more and more like kind of clinics are using, people are using more and more dynamic ones. If I have to compare between the advantages and disadvantages, I would say that the static ones, it's difficult to regulate the pressure. Now, if you want to change the pressure that you want to give to the limb, you would have to usually either change the garment, like again, re-prescribe the garment, or open the bandage, do the bandaging again, if you want to change the pressure. So pressure control is difficult with the static devices. Although one advantage of that one is that it is easy and easy for the person to move around, I would say, because it's not connected to anything. Now, if I talk about these pumps, most of the pumps which are available in the market currently, they allow the pressure to be regulated and they have different ranges of pressure available. But the drawback is that the patient has to be around a power plug because they need to be connected to an electric supply. So this is, I would say, one of the big disadvantages of these pumps. If the patient is more active, I totally get that. If the patient is not mobile, not active, like seriously deconditioned or seriously ill, probably they do not need to move around. But people who are more healthier and can move around, I would say that if there is a possibility that we can kind of have, or towards again doing more research, that if there is a pneumatic device that can allow the patient to move around and let them be active, is my opinion, that that's the biggest disadvantage.
Thank
Angelo.
you, Sonia. Thushan, any thoughts on graduated versus uniform compression? Because Sonia mentioned there are some mechanical devices that has one pump, one chamber, and some are like multi-segmented chambers. So definitely for multi-segmented chambers to have graduated compression, can you give some thoughts on where we can use these type of different compression profiles?
Sure. Yeah, so I mean, Sonia explained pretty clearly how the compression and the static and dynamic compression works. You can divide it in many ways. You can make it static, dynamic. You can make it active, passive. But basically, regardless of what modality you use, there needs to be a resting pressure when the patient doesn't do anything, and there needs to be a mechanism for the pressure to be created when the patient walks. The patient is not doing anything. There's a different mechanism of creating a pressure head for the fluid to travel. But if the patient is walking, that automatically causes different pressure head based on their movements and activity. Now, if blood flow travels as in any liquid, like I said before, according to a pressure difference, there needs to be a high pressure point and there needs to be a low pressure point. If we are using a single device or single stocking that creates an uniform pressure, let's say it's 30 millimeters of mercury from the toe up to the hip or the knee, the pressure difference is not created at rest. But if the patient walks a bit, and that will create a different pressure difference, and therefore blood might flow. But based on a passive compression, based on a static compression, based on a resting pressure alone, there won't be a pressure difference. To overcome that, the market has devised a method of creating a graduated compression stocking. For example, in those stockings or those devices or those compression methods, there is a higher pressure at the ankle level, but a lower pressure at the level of the knee for a below knee stocking, or at the level of the thigh or the hip for a above knee stocking. And through that pressure difference, through that graduation of the pressure from a high to a low pressure, blood can, or tissue or fluid can therefore flow. And the effects of a venous hypertension or lymphedema or tissue fluid after surgery can be avoided. That is all and well and good for a person who can walk around and who can mobilize and do stuff. If even with a normal resting pressure or a static compression, the principle is the patient needs to be able to walk and move in order to create a pressure difference when the patient is walking. Otherwise, there needs to be an active compression to create that pressure difference. And that is how pumps and sleeves, if they're appropriate, how they can create the different pressure head. So the fluid will travel in those instances. And that is why, especially people who are finding it difficult to walk, who are too old, who have defects in their pumps, a graduated compression device alone might not be helpful unless there's an active compression or external pressure to push the fluid up. Does that make some sense, Angelo?
Yeah, that's great, Thushan. I think we kind of we can move on to our next topic with the concluding remark that active compression versus static compression, they have pros and cons, and also we kind of understand where we need to use them. So there are specific situations that we need to use static compression socks, and also with active compression you have much more controllability. You can obtain the sequential and the graduated compression. With that, Dr. Parakrama, we like to understand when it comes to athletes or post-surgery, what sort of pain points that we would like to address when it comes to, so there are different techniques, right? We have static socks, we have mechanical pumps. What are the user case? What are the things that we need to solve right now? Any thoughts on that area?
Yeah, mostly like Sonia mentioned, what we have right now are like graduated compression. The mechanical devices are used on patients who are stationary, just post-operative, and then that has to have a direct power supply. So that is a great disadvantage that I see as an orthopod. Whereas if we are able to, because now we orthopods are moving from post-operative patients or post-injured patients being bed rested to allow them to move around and then allow them to recover. So early mobilization is the way forward in orthopedics. So if we are able to have devices that patients wear or worn while they are mobile, so that would give the that would definitely add into their recovery, and then they'll recover faster. And then I have given some slides to Shahir to show some orthopedic compression devices or external devices that we use. Now, for example, this is a simple shoulder brace, and these shoulder braces can be incorporated with, like Angelo said, cold therapy, hot therapy, the heat therapy, because now post-operative, let's say I have done a shoulder replacement or a rotator cuff repair, then if I'm able to incorporate some device that maintains coolness around the shoulder, that would definitely enhance bleeding, definitely reduce bleeding, thereby reduce the pain, etc. And then there's another one, Shahir. Yeah, so for example, this is immediate post-operatively, we use these devices to immobilize the knee joint. And if we are able to, now these are frequently used products, so if these products can be used with additional mechanical compression plus cooling or heating systems incorporated into these things, so that would again add value to these, and then that can be again the future. So this is another device, ankle replacements, ankle open reduction fixations, etc. Now the people have moved from wearing casts to wearing walkable or mobile boots like this. So these can again be incorporated with heating and cooling devices on the go. That would definitely give an additional edge, and then their recovery would be faster.
Thank you, Parakrama. So, Sonia, just want to understand a little bit about pain points from the physiotherapist point of view for health and wellness consumer. Let's say elderly consumer, seniors who are suffering with tired and achy legs. When it comes to static socks, what are the issues that they have? Not only static sock, even the mechanical devices. Putting it on, sometimes they are not able to put them on by themselves. Can you address some of these issues that you came across with your patients and with your patients at your clinic?
Yes, yes, Angelo, there are sometimes instances when these patients have difficulty putting on these garments, I would say more, because bandages we usually do it, and then when they have to put the garments, people especially who have arthritis in their hands and their hands are painful, it gets a little difficult for them. And if you need more pressure stocking, it is more difficult to put it on. So high pressure ones are difficult to put it on again. So arthritis especially, and I have sometimes also faced issues when the patients are like stroke patients. When their one arm and one leg is functioning well, but the other arm and the other leg is not functioning well. That time again, if it is their, if they have to do something with their, impaired arm, it gets difficult for them to put on the orthosis. So definitely, thinking about some of the assistive devices that we can give to these patients, some easy to hold on things, or easy to hold on, grab these compression devices or these garments to put it on would be very helpful. I definitely agree with that.
Thank you, Sonia. And Thushan, just wanted to understand with the static compression socks and also from the mechanical compression devices point of view, the pressure levels that we really need to apply, because there's some sort of a controversy, especially sometimes athletes, they request higher compression to be applied after a game. But actually, when it comes to active compression devices, we can control the compression. Static compression, it's much difficult to control. Just want to get an understanding about what is the right level of compression. If there is any research showing what's compression to be applied, what level of compression?
Yeah. So, Andrew, as a clinician, and as a vascular surgeon, our primarily patient population revolves around those who are referred for edema, and they are primarily either due to what's called chronic venous insufficiency or venous hypertension because their veins aren't working, or those with lymphedema, or the lymphatics aren't working. The sport person, I think Parakrama will probably explain a little bit more from his point of view. When it comes to pressures and compression and our clinical patients, you look at venous hypertension, for example, the understanding is that we need to create a pressure head at the ankle compared to the thigh or the knee. And at the ankle level, we try to create a pressure of around 30 millimeters mercury or around 40 millimeters mercury. And there are stockings and garments that are designed to create that pressure at the ankle. For example, there are different classes, different types of stockings based on whether you are in the US or the UK. The class will be different, but roughly around 30 to 40 millimeters of mercury of tissue pressure will be required at an ankle level in order to create that pressure difference. And that is for a static pressure. That is because if the pressure is anything more than 30 or 40 for a sustained time, then the tissue perfusion will get affected, and therefore the tissue will become ischemic. Now, a couple of things about this. One, as clinicians, when we ask a patient if he's talking, or sometimes with ulcers and venous issues, we use what is called a strapping, where we manually put a bandage around the leg to create that pressure. One, with a stocking, a patient uses this for some time, maybe 3 months or 6 months sometimes, and there is no guarantee that the elasticity of the stocking is going to remain at that same level throughout the particular time. And obviously, after a few weeks, there is unlikely to be the pressure at the ankle that is required with the stretching of the elasticity. And if you use things like bandaging and compression bandaging, it's basically a clinician who decides how much of tension, how much of stretch on that material is used to create that pressure. There's a lot of interpersonal variation, a lot of interpersonal variability in using these bandages specifically, and even with graduated compression stockings, there is no guarantee that the pressure exerted remains as such over a particular period of time. Now, that is about static compression. And if you're using active compression or pressure pumps, which basically are intermittent in nature, then we can use even a higher pressure, because there's a time of pressure where the tissues can get perfusion back. So in these devices which using pumps and stuff, if we can use a pressure intermittently, then we can even go up to higher pressures, and sometimes people use even up to 70 or 80 millimeters of mercury as intermittent pressures to create a pressure head. For specific instances, maybe things like lymphedema rather than just simple lymphedema. But to answer your question about pressures and how it works, if it's a static pressure, it's around 30 to 40 millimeters of mercury. If it's intermittent, then you have the flexibility of manipulating the pressures to a particular pressure you want. And because it's intermittent and not sustained, there is no effect, long-term effects on tissue perfusion. And like I said before, a lot of cons in regards to stockings and bandages in ensuring that the pressure exerted is actually the pressure we want, and also a lot of issues in terms of ensuring that the pressure remains like that for a particular period of time, and the flexibility of manipulating the pressures or the graduation is not there in these static devices.
That's great, Thushan. I think that's a really great explanation on what level of compression need to be given when it comes to static versus the active compression. So with that, would like to move on to our next topic. There are a lot of people join from different audience joining from companies that are developing compression product. So would like to all the panelists to come together and give your thoughts in terms of what are the add-on technologies for within this static and the active compression both. So Dr. Parakrama, if you could give us a little bit your thoughts on what are the add-on technologies when it comes to static and active compression, or even braces. Yeah,
I think I briefly mentioned about it before. From orthopedics point of view, add-on to braces and then the compression devices. Braces, of course, as I mentioned before, we generally use post-injury or post-surgery. So in my point of view, adding on a cooling device or a heating device would definitely help the recovery of the patient following a surgery or injury. And in addition to this, graduated compression stockings, etc., the mechanical devices, if they can be made portable and on-the-go devices, so that is what I am looking at. If we are looking for new developments to what we already have, so those are the additions that I would suggest that we should develop in the future.
So, Dr. Parakrama, you mentioned about cooling and heating together. Uh, if you could elaborate on a little bit on what comes first when it comes to post-surgery recovery.
Yeah.
Is it
So,
heating or cooling?
yeah, so sorry for the confusion, but we do use cooling mainly post-surgical and post-injury recovery. That is immediate post-surgery, immediate post-injury recovery. And then heating is mainly for pain relief. So those are for mainly for chronic pains that we use heating. Am I right, Sonia?
Yes, Dr. Prakram, you're absolutely right. So we start with the cold and then heat later until the swelling is gone. We don't start heat. Yeah.
So with that, Sonia, I think you can also
Yes.
add any comments that you might have in terms of, because you touched on a few things previously. You said about mechanical pumps that are available in the market. They are bulky, they are tethered, and also you mentioned about static compression stockings being difficult to put it on. So these are some of the pain points. With that, uh, what are the improvements that we can do for these devices, and also what are the additional technologies that we can incorporate with these devices to give the added benefit to the end user?
Yeah, so one of the very important ones, Angelo, which Dr. Parakram also touched on, is about giving the patients flexibility to move, especially who are functioning patients. So giving them flexibility to move and not letting them sit around with that plug powered to their compression device could be one. And while I am talking about being active and mobile and being a physical therapist, that's one of the most important thing that I see in my patient is that they are mobile and active. If there is a possibility of having this device to be able to put on people while they're moving and active, and also how to measure the activity level in these devices, like how to measure and keep a track of what was the activity of that patient, and while even the compression, how to regulate that compression. If we give these devices for the patient to take it home, how can we regulate that compression? Along with that, if there could be like an I don't know how is that even possible, but I'm just saying this. If there's a way to measure or do a circumference measurement of their limbs for the edema, like an easier way. So I'm thinking more about making patient independent and making patient being able to take this device if possible at home and be able to do all of these things in an easier way. When I treat patients, this is the difficulty I see, that either the compression devices we have in our clinics, it's like patient comes in and we put it on them, but like making it more accessible, more patient independent, patient takes home and keep it, and then we can record if there's a way of monitoring all of this, what patient is doing at home is how I see more practical.
Great. Dr. Thushan, any thoughts from your side as a medical practitioner treating venous ulcers and also venous insufficiency side of things, where we can add any technologies? Like few things Sonia touched on, measuring the swelling, measuring the compression. Any thoughts?
Yeah, I mean, Angela, from our point of view, I think this is a common problem for all clinical clinicians who are involved in compression or venous insufficiency or lymphedema. Compliance is a big issue. All the major trials of compression devices and stockings are used either for venous insufficiency or for post-thrombotic syndrome. They're very clear that people do not use these stockings. Even the big SOX trials and other trials, compliance so poor. I mean, majority of people who are supposed to use these stockings for 7 days of the week during the daytime but 90% of them don't even use it for at least 3 days for a week. So the need to have a mechanism that will allow for compliance and make sure that people use these compression devices is important. Stockings doesn't seem to be the way forward, and perhaps a device that will allow a patient to use it, to take it off and use it when it's required, user-friendly, easy to use, easy to take off. These sort of things will be useful for a device in future. And the second thing in clinical practice is what is important is not the pressure that is on the product or the product leaflet, is the actual pressure at the interface between the device and the skin. And the tissue interface pressure, or knowing that pressure, is really important so that we know that the efficacy of what we're doing is there. Otherwise, the device may have a 30 millimeter pressure, but it's not there at the end of the day. And a method of calculating or having a pressure reading would be really useful to find out if that pressure is actually there, as well as to make sure the pressure sustains with time. And having a device that gives that negative feedback of a tissue interface pressure, I think this is a way forward in technology and in a future compression device. Thirdly, I think Sonia will agree with me on this, especially with lymphedema. The way we apply compression is different. The lymphatic drainage has to be from proximal first to clear those proximal nodes, proximal lymphatic vessels, and then gradually come up the leg and so forth. And the compression devices or the compression stockings does not allow that. I think having a multi-chamber compression device that gives us the flexibility and the ability to manipulate the pressures as well as the compartments would be really important, especially with lymphedema and others, even for sports, for example, when only a particular area of the body is required to be compressed, or we need to have a different pattern of compression. Have that maneuverability and the flexibility is really important. I think those, for me, those three things are the things that are really going to be pushing for a proper comprehensive compression device from a clinical point of view. Angelo?
Yeah, thank you very much, Thushan and Sonia. There are a lot of good insights for all the compression manufacturers who are joined at this webinar, for them to kind of go back and brainstorm and think about how they can integrate the different technologies in order to get us the right compression level, monitor the compression, whether the compression is correct, and also the remote patient monitoring. Those are the key things that we, I think, identified as a key add-ons. So there's one question from the audience. Would any of you can take this question? Curious about safety of pneumatic compression during pregnancy. I think that's something that a user segment that we did not discuss in this panel. Why don't we have a discuss on that side as well? Any of you have any comments on that?
I'm happy to start off. I think as clinicians, we are usually involved in pregnant females with who are at risk for DVT, who are with pregnancy has increased venous hypertension because the pressure on the pelvis creates a higher pressure on the draining veins. They're more prone to having varicose veins, they're more prone to DVT, and therefore they have lower lip swelling. A lot of people are referred to vascular surgeons in the pregnancy period because of lower limb edema and those sequelae. And in those patients, compression devices are used. Mainly what we use are static pressures. It may not be the best thing to use a pneumatic compression for some females, but in general, the compression device is safe. It is usually required for people who have symptoms and who have complications during pregnancy. I'm not sure whether it is required for every single pregnant women who are not symptomatic, but majority of people do have edema, lymphedema, leg edema, venous edema, and are at risk of DVT. Their mobility is restricted, and those people, compression devices are often prescribed and used from our point of view. Angelo?
Thank you, Thushan. Sonia, Parakrama, do you have any thoughts?
I I think Dr. Thushan covered it really well. I have also mostly used the compression socks for pregnant women. And again, when it is indicated, not like all of the pregnant women.
I stick to what Thushan and Sonia suggested because it's not my area. Anyway, it's quite self-explanatory that it is safe to use because it's for symptomatic relief, because elevation of the pressure in the pelvis causing venous engorgement, causing swelling. So if we are able to reduce that, they will have symptomatic relief. So it is safe unless they are proven to have deep vein thrombosis and then wearing stockings. What do you think about that, Thushan? Like if they have DVT and then without knowing be using compression devices, what is the safety of that? Is it safe?
I think a lot of worry that a compression device or compression during DVT can cause a risk in terms of dislodging clots, and therefore clots can embolize and cause pulmonary embolism. Active compression is probably not the best thing, and probably best avoided in patients with active DVT. But patients who have DVT, they should be on compression stockings, and that should be a static compression stocking device in order to prevent propagation of the clots, as well as to perhaps potentially reduce post-thrombotic syndrome or long-term sequelae of DVT. So in patients with DVT, it is okay to use a static compression device. An active compression device would not be suitable in those patients.
All right.
Great.
Thank you.
Parakrama, going back to our set of questions that I wanted to address on these add-ons. One of there are some products, and especially for athletes, because they are requesting high compression because they wanted the compression, them to feel the compression. So probably they use foam rollers to kind of recover after a game, and some people use foam rollers with studs on it to provide like kneading and the localized pressure compression. Any thoughts on this? Is it really kind of a feel factor, or is there any scientific reasoning behind that?
But those are purely, I would say, that kind of compression to relieve pain, that is purely to stretch the muscles and then sort of get a comfortable feeling, more than for drainage of the blood or the lymphatics. So that's my experience as well as my observation. So foam rollers are, Thushan, I'm sure he would agree with me, because post exercise or pre-exercise, when they use foam rollers, that is to stretch the muscles so that recovery is faster and then there's no stiffness developing in the muscles. And then to add on, I mean, since you talked about add-ons, another thought that came to my mind was like, you said that there are some compression devices with the studs attached to it. So if one of these compression devices, if we can, like flimsy device with, we use something called, and physiotherapists use TENS, muscle stimulation. So if we can incorporate tiny electrodes to stimulate muscles whilst they wear a very thin, or I mean not a bulky product, so that would also enhance the muscle stimulation and thereby increasing the venous and the blood return, and thereby reducing pain and swelling.
Yeah, thank you for that great answer. So we have another question from the audience. With integrating compression sensors, what are the limitations seen getting sensors within compression garments? And also, what are the expected girth variations you can see in a lower limb edema? So if we are looking for developing a sensor that can measure the edema or the swelling increment or the reduction with the compression. What are the variations in girth? Maybe Sonia, do you have any idea on, like, after using active compression, how it changes?
Yes, so as far as I have experienced, we have so I have measured in percent, I would say. So we have gotten about like 35% reduction most of the times in different patients wherever we have used these devices, or we have done drainage or whatever. So about average, I would say, but yes, it can range. It can range from if I go maximum, maybe like 50% usually to like 20%. I've usually definitely seen 35% reduction in the edema. If that helps kind of give you a range.
Yeah, sure. What sort of patient groups, Sonia, you referred to here?
So I'm referring here mostly to these cancer patients who develop edema after lymph node removal.
Right. Okay. Anything to add, Thushan, there?
Yeah, I think Angelo, one question was about pressure sensors. I think it's really important that there needs to be a safety aspect for using pressure sensors in compression devices. Any external device or external object in a compression device can result in a localized high pressure point, and that can cause tissue damage or tissue destruction or cause problems. So it's really important that whatever sense that is integrated is safe. That is the first thing. In terms of girth reduction, I think, like what Sonia said, it's important to understand what the cause of edema was. For example, if it's venous hypertension and edema, that fluid, almost all of it, can be gradually brought back into the circulation, and you can get rid of that tissue fluid. And you can go up to about 7 to 80% of girth reduction in terms of chronic venous insufficiency. But the same thing won't apply for lymphedema, because the edema fluid is different. There's a lot of protein in that fluid, and therefore the protein can't be brought back into the circulation with compression. And therefore you cannot expect that degree of girth reduction. And I think Sonia's 35% is brilliant. Most of the time it might be even less than that, maybe around 30%, 25% girth reduction for lymphedema, depending on the stage of lymphedema. In an early lymphedema, you might be getting better girth reductions, but with more chronic and lymphedema, maybe levels grade 3 or grade 4, you cannot expect that amount of girth reduction. But I think those are the main things that I can think of.
Great, Thushan. I think with that, we kind of come into an end of this webinar. I think we have answered all the questions that came from audience as well. So I think for the audience, if you have any further questions to kind of address, and I think there were a lot of insights came, what sort of add-ons, what sort of consumer pain points from the sports, health and wellness, and also from the medical angle. If there are anything that wavtec team can address, please reach out to us. We are happy to engage with anybody who want to kind of address these issues and come up with a novel, innovative product to market. We are happy to work with them. And also we have a great panel that who are helping us kind of advising and performing research with us. Dr. Parakrama, Dr. Thushan, Dr. Sonia, and many other people. And also we are planning to get them involved in the next webinars to come. So with that, thank you very much for joining us. And also again, would like to thank Dr. Parakrama, Dr. Thushan, and Dr. Sonia joining us and giving your valuable time at this first webinar of wavtec team. Thank you very much.
Thanks, Angelo.
Pleasure. Thank you.
Thanks, Angelo.
Thank you.